अऊज़ु बिल्लाहि अस्समीउल अलीम मिनश शैतानिर रजीम बिस्मिल्लाहिर रहमानिर रहीम। खुदा ताला आली कदर मुफद्दल मौलानी उमर शरीफ में तारोज़ क़यामत दराज ने दराज करे।
आमीन।
અને આપ મૌલાનું શુક્ર કરીએ છીએ કે આપ મૌલા એ अपन સગલા હેલ્થ કેર પ્રોફેશનલના વાસ્તે ઘણી દુઆ ફરમાવી છે. Thank you for joining this webinar, the third in the series. By default, you all will be muted throughout this webinar. You can type in your question in the Ask the Question box at the bottom of your screen. Throughout the presentation, we invite you to type in your question and comments in the chat box. We will respond to those questions near the end of the webinar. Today's webinar is regarding neonatal cholestasis and brief review of GI liver issues related to COVID. And our presenter today is Dr. Batul Kaj-Carbidewala. Dr. Batul Kaj-Carbidewala is a practicing GI hepatology nutrition transplant physician at Laurie's Children's Hospital and also an assistant professor at the Northwestern University's Feinberg School of Medicine. So without any further delay, we welcome Dr. Batul. Dr. Batul, shukran for coming in, and the floor is yours.
Shukran Hatim Bhai, not only for the introduction, but also for all of the technical support. Salam al Jamil to all of the participants. Let's get started. So Ajay talk show, I'm going to be covering neonatal cholestasis, so some of what it means, what jaundice is and what cholestasis is, and then very briefly covering some of the main GI liver issues that have come up with regards to COVID-19. So let's start with cholestasis and jaundice. So objectives are to review the causes and definitions of neonatal jaundice and cholestasis. We'll discuss the first tier workup. So that's basically, as a primary care or pediatrician, what can you do before referring to a specialist, and then when to think about referring. We'll talk some about biliary atresia. And then, like I said, we'll go over the GI liver manifestations of COVID-19. So first, let's review the bilirubin metabolism. This is a little complicated, but important to remember. So Ajay, if you look at the top left-hand corner, bilirubin comes from the breakdown of red blood cells and specifically hemoglobin. So that can happen really anywhere that the red blood cells break down, but primarily in the spleen. Then the bilirubin sort of makes its way to the liver, where it goes through a pretty complicated process of metabolism and conjugation, and ultimately goes from the liver down into the intestines. Some of it then gets excreted by either by the urinary or GI systems. Some of that bilirubin or bile and bile components get reabsorbed via the intrahepatic circulation and reused essentially back into the liver and reused. So this all becomes important when you think about some of the causes of why you can have hyperbilirubinemia. So the first thing, to think about is when we think about yellow babies, right? So most of the cases end up being what we call physiologic jaundice. And most of you will have seen this Bhutani nomogram. So in thinking about physiologic jaundice, this is specifically unconjugated hyperbilirubinemia, meaning the bilirubin is high, but it's the unconjugated form. So before it gets to the liver and gets conjugated for excretion. And that's also an important differentiation. Physiologic jaundice, where, it's something you don't typically have to be worried about, is mild, transient. So typically the first couple of days to 4 days of life, the peak is usually about 5 days. Generally speaking, it should not last more than 2 weeks of life in a kid who's feeding well and growing well, etc. Most of the time, physiologic jaundice is a result of a couple of different things. One is babies actually have a higher concentration of red blood cells, and as a result, they break down the red blood cells faster. So this is pretty typical of all babies. Next, the bilirubin clearance is decreased in all babies as a normal thing, just because they have this transient deficiency of the enzyme that is necessary for this process, and just because actually the liver is a little bit immature with metabolic processes. And they also have somewhat of an increased enterohepatic circulation compared to adults, meaning that the bile gets reabsorbed much more quickly into the bloodstream than in adults, and so that contributes to the high level. Just to quickly review, this I feel like comes up a lot when we think about jaundice, is what's the difference between breastfeeding jaundice and breast milk jaundice? There are a couple of key differentiations, but the most important takeaway from this slide is that generally neither of these should stop a mother from breastfeeding. Neither should that be typically recommended unless in specific situations. So with breastfeeding jaundice, it really shouldn't be called that anymore. It's really nothing to do with the breastfeeding. It's more just they have suboptimal intake. Generally, this is present in the first week of life. It's due to just either they're not taking enough milk or they're dehydrated, something like that. What happens in that situation is increased reabsorption, so due to the enterohepatic circulation. Most of the time, you sort of persist as the breast milk comes in, and as the babies continue to learn to feed better, this gets better. Breast milk jaundice is a little bit different, can last a little bit longer, but generally not longer than 2 weeks. And this is specifically because of some of the components of breast milk that change the metabolism of bilirubin. So one of the big players is beta-glucuronidase, which is an enzyme that affects the conjugation of bilirubin. This also typically self-resolves. So even if mothers would like to continue to breastfeed throughout this, you can. Often, folks will try switching to formula for a few days and seeing if it improves. Generally, I don't recommend this unless it's we're at sort of pretty high levels of jaundice, and if the baby is otherwise unwell. But so those are the key differentiations, and generally continue to breastfeed throughout. So then the question becomes, when is it not physiologic? When should we be worried? So a general rule of thumb is any jaundice that is present within the first 24 hours at a high level should be thought about more carefully. If they're a very high level, so if we go back to this, the nomogram really quick, there are percentiles. So you can plot based on the age, where they are. And if they're greater than the 95th percentile, that's also somewhat concerning. If the bilirubin is becoming higher despite the use of phototherapy, or if this is a prolonged issue. And just to clarify, this is still talking about unconjugated hyperbilirubinemia, meaning it's that bilirubin, it's not the cholestasis part, it's the unconjugated bilirubin. So here, the possible causes really fall into a couple of different categories. One is increased production. So this can happen in situations like blood group incompatibility, where you have hemolysis. That's considered immune hemolysis. Then there's also non-immune hemolysis. So if you think about those children that are born with the big bruises, the big cephalhematomas, as those are broken down and the red blood cells within that hematoma are broken down, that increases your production of bilirubin. Any type of red blood cell defects, so that's both things like that change the shape of the red blood cell that make them broken down more easily, or if there's an enzyme defect, such as G6PD. Then the other thing that can happen is you have decreased clearance. So this is typically more with congenital or genetic issues related to the enzymes. So I'll call it UGT. It's a very long name. Uridyl something glutamyl transferase. UGT is the enzyme that can, mutations of this enzyme mean that you can have some of these syndromes. Again, typically don't cause too much of an issue, but cause you to have this prolonged hyperbilirubinemia. Maternal diabetes and congenital hyperthyroidism can also contribute here. Increased enterohepatic circulation, we talked about a little bit. Breastfeeding, we talked about. Intestinal obstruction is more just if things are sitting in the gut longer than they should be, the likelihood is that the bile acids and the bilirubin gets reabsorbed more readily. And finally, cholestasis, which is something that we'll focus on a little bit during this talk. And so those are the causes that you think about when you have a baby that's jaundiced for either within the first 24 hours or greater than 2 weeks, really high levels, or that the levels are rising despite phototherapy. So now let's talk about cholestasis. So cholestasis is present, actually, George, out the relatively common, 1 in 2,500 term infants. What happens is you have reduced formation of bile or reduced flow of bile, and as a result of that, the biliary substances stay in the liver and can cause trouble. Just as a note, cholestasis by definition does not equal an elevated direct bilirubin. for reasons I'll talk about in a second, the two do not mean the same thing, but the two often occur at the same time. And the reason cholestasis could be any of these, so bile itself doesn't just have bilirubin, it has all of these other things in it too. It has bilirubin, it has bile acids, cholesterol, and phospholipids. And basically abnormalities or transporter issues for any of those things can change the component of, can change the sort of the composition of bile and mean that it doesn't flow the way it's supposed to. So the common thing that we think about when we think about cholestasis or elevated direct bilirubin in these jaundice babies is if you have a conjugated or direct bilirubin greater than 1 milligram per deciliter. But remember that these other components can be affected also. And that's what I just said. So this is not to make you nauseous. It makes me a little bit nauseous, actually. But just to give you a sense that at a cellular level, bile formation and transport is incredibly complicated. And actually, we are learning more and more about this all the time. Genetic mutations that lead to specific transporter defects and blah, blah, blah. But I think the most important point here is that it's a complicated process. A lot of factors can be abnormal in contributing to this issue. So now when we think about, when to be worried and when to consider referring to a specialist. So this is in when you think about either a high bilirubin level or in some of these other situations. So sorry, my decree, here. Okay, so the first thing, and this is sort of a fairly obvious statement, is any infant that has hyperbilirubinemia, whether it's conjugated or not, if they're ill appearing, right? So if they have any signs of sepsis, infection, being in shock, and we'll go over some of these, that should definitely have some alarm bells ringing. Second thing we talked about this is within the first 24 hours of birth. And then when we think about prolonged jaundice and definitions, right, it's a little bit different for formula-fed versus breastfed infants. So the rule of thumb is for formula-fed infants, they should be, if it's lasting more than 14 days, you should be worried. And breastfed infants, 21 days. But the important thing is that they shouldn't have any of the risk factors that we are about to discuss. So outside of those four categories, the following red flags or symptoms that should worry you are these. So, right, if there's anything in the prenatal or delivery history that is worrisome for infections, for liver issues in the parent, if there are in the mother, any ultrasound issues in the prenatal ultrasounds on the baby themselves, concern for infections, prior history of newborn death or hemolysis. This doesn't happen as commonly anymore, but there certainly you can have intrauterine death and early infancy death, pretty significant immune hemolysis. That's something to be aware of in the family history. If the baby is not feeding well, is not urinating well, and this next part is important, acholic stools. That means stools that have no pigment to them. So Archie is actually very important, Chit, that the stool color you must always look at in babies with jaundice. You must always try to look at it with your own eyes. While parents, and actually people have studied this, parents are okay at deciding what the stools look like, but a physician or a provider looking at that stool has been shown over and over again to be the most sensitive thing in determining if a baby has acholic stools. So what the acholic stool means is that the biliary pigment is not getting into the stool. And that's a good indication that there's some obstructive process going on. Bijuke, abnormal newborn screen, the thyroid function, things like galactosemia, other metabolic diseases that most states within the US now mandate screening babies for. Failed hearing screen is another clue. There are certain syndromes in which the baby can have hearing loss and jaundice. And then just the sort of general examination findings like dysmorphic features, any abnormalities in the vital signs, which sort of speaks back to the sort of ill-appearing kid. And then any abnormalities, particularly feeling for a large liver or spleen, that would be important too. So just to kind of summarize that, any infant that has jaundice, that has any of these red flag symptoms or signs that we've talked about, should really prompt immediate evaluation, right? So that means bringing them into the ER or to the hospital for an admission and start thinking about some of this additional workup that we'll talk about. So let's say you're in the ER or you're in your clinic and a baby is in front of you. You're worried about the baby and the baby looks yellow. So what are some of the things that you're going to think about? So if they have temperature instability, they're feeding poorly, they have lethargy, sepsis, no matter what that situation is, you must always consider sepsis, because that is, in the neonatal period, has a really high risk of mortality. But some of the other things, if they have, if they're sort of tired, they're vomiting, poor feeding, respiratory distress, so actually, and any abnormal movements or seizures, think of metabolic diseases. And then if you add to that a baby that has hypoglycemia or has recurrent infections or has any abnormalities on their examination, then think of endocrinopathies. Now, this, of course, becomes a lot of this even outside of my wheelhouse, to be honest with you, but at least recognizing these early signs is important to then refer or get the kid appropriate care. So we won't go through these in detail, but may include Kideluche just so you have the sense of what are some of the things that you should do. So the sepsis piece, right, is really important. So you want to think about bacterial and viral causes. Of course, you're going to do all of the testing, CBCs, BMPs, culture, everything, right? Think about LPs in this situation, depending on the child's age. Certainly less than 6 weeks, you want to think about an LP also. The viruses that can often cause jaundice are these listed here. So herpes simplex is a really big problem. The herpes simplex, hepatitis or cholestasis in the newborn period has very high mortality, so close to like 80-90% mortality. So the only way to save those babies is to treat early. And so any kid, generally speaking, who is sick and has jaundice and is, fits the age range, so really anything less than 6 weeks, we would most likely have that patient on IV acyclovir while all of the testing is pending. So empiric treatment, right? Generally, antibiotics they get empirically. Then some of the other things we'll discuss in the next slide too. But when you're thinking of metabolic diseases and endocrinopathies, think about hypoglycemia is one of the biggest things. Ammonia levels can be helpful, and lactate. These kids, think of them as more sort of systemically sick with metabolic type issues. So you want to think about getting blood gases, glucose, lactate, ammonia, these things, in addition to the other workup that we've talked about. The endocrinopathies, there are some, certainly, panhypopituitarism can sometimes present with jaundice, actually often does. More often than not, they have other signs, features of, hypotension. If with panhypopit, they can have some other issues. And in fact, if you have septo-optic dysplasia, which is rare but links jaundice and hypopituitarism, they will have some ophthalmic abnormalities as well. The nice thing is that, if you look, there's a lot of crossover between some of this testing, right? So you can do sort of a basic screening and capture most of the abnormalities that you might see in any of these sick appearing infants. So now when thinking about prolonged jaundice, like what do you do with that baby who looks fine, seems to be fine, not sick, but it's been 2 weeks, 3 weeks, and they're still having this high bilirubin? So the most important thing in that situation is to fractionate the bilirubin. So that means when you're checking the bilirubin, you send the blood test, make sure you get total and direct. So you can either order it like that, or you can order total and conjugated. Really, really important to have that fractionation, because that's the only way that you're going to know, is this cholestasis or is this just an unconjugated hyperbilirubinemia? So that's a really important takeaway. So when thinking about when do I get the GI liver specialist involved, generally we like to be involved in everything, but most definitely they're sick and they have jaundice, if they have prolonged jaundice, or if there's essentially cholestasis where the baby has a direct bilirubin of greater than 1 milligram per deciliter, then get us involved for sure. The things that we often think about in the immediate sort of neonatal period is distinguishing between, is this an extrahepatic or obstructive cause or an intrahepatic cause? And I've laid out here some of the main differentials that we think about. Biliary atresia, for reasons that we'll discuss, is one of the most important diagnoses to make early. Some of these other ones, you may not even have heard of some of these. They're very, very rare. PFICs, bile acid synthetic defects. But these are, some of the things that we think about as causes in these babies. And the testing is sort of driven to mostly rule out these things. Another way that you can think about it, and again, this is an important takeaway, is in these babies, from a primary care pediatrician perspective, you really think about trying to get this GGT level done. That's the gamma glutamyl transferase. That can give us a lot of additional information as part of the screening, basic screening lab. So we sometimes will split them into, does this baby have cholestasis with a low GGT or a high GGT? And then, so that can help us kind of differentiate some of the causes. And then sometimes looking at the pattern of elevation of liver enzymes can be helpful also. So to give you an example, if the enzymes, so if the ALT and AST are really high, but the elevation in bilirubin is low, then it may prompt you thinking about sort of intrahepatic causes or hepatocellular injury that is sort of early in the course that hasn't developed the cholangiopathy or bilirubin part of that. If you have a high bilirubin, but the AST, ALT are normal, then that sort of makes you think, is this an obstructive cause? Is it that the problem is further down in the biliary tree, and that's what's contributing to that bilirubin? So it can give you a little bit of clues as to how exactly what the elevations are. We've touched on this a little bit already. So the most important things to diagnose early are sepsis, of course, right? High mortality. Metabolic diseases, again, because if they go undiagnosed for a long time, it can really, if you have a sort of sky-high lactate, sky-high ammonia, that can really impair your neurocognitive development. Endocrinopathies, of course, too, can really affect, sort of treating early can really promote good growth and nutrition going forward. And then biliary atresia that we're going to spend a little time talking about later. So this is mostly everything that we've talked about, but just splitting it up into what can I do as a pediatrician, a community physician, a PCP when I see these babies, right? And then what are some of the things that my specialist colleagues are going to think about doing? So it's a busy slide. I apologize for that. But, the first and most important thing that you can do in a baby that has jaundice is to identify, is the baby sick or not sick? And then figure out, is this a treatable condition or not? And those are some of the things that you can think about: blood, urine, fasting, ultrasound, maybe. And then once you get into the more complicated things of, what else do I need to think about? This is, you work with the specialist when possible, and you think about some of the more specialized urine and blood testing, sweat chloride analysis if there's a concern for cystic fibrosis. Think about imaging and assessing other organs to look at some of the syndromic causes. We aren't going to go into too much of the syndromes. That's going to be a whole other talk in itself. But this is just included as a complete reference to see what are some of the things that you can think about for the evaluation process. A quick word on the imaging options. So this is now thinking about, you identify that the baby has cholestasis. So they have a direct bilirubin of greater than 1 milligram per deciliter. An ultrasound we generally will do on all of those children. And that's something that, primary care providers can totally do. Remember, though, that ultrasound is not good for determining if a patient has biliary atresia or not. Because even if you see a gallbladder on the ultrasound, or if you don't, these are not diagnostic of biliary atresia. What we mainly use it for is to rule out things like choledochal cyst or biliary tree abnormalities that are much more readily seen on ultrasound. And it can help with looking at the size of the spleen and the liver. You can get measurements that way. But remember, ultrasound is not diagnostic for biliary atresia. HIDA scans have been used a lot, actually, in the evaluation of cholestatic infants. Here in North America, we use them less and less, and I would say probably in the UK also and Europe. I'm not so clear whether they're still being used in other places. I think certainly they are. The way that a HIDA scan works is you give a contrast agent intravenously, and you essentially wait to see the uptake in the liver and then whether it's getting excreted into the biliary tree and subsequently into the GI tract. The thought was with biliary atresia that you should get non-excretion, right? So the contrast doesn't make it from the liver to the GI tract, because in biliary atresia, the bile ducts and the gallbladder, they're atretic. They don't connect to the gut. The problem is that it's not helpful because there are many reasons to have a non-excreting scan. There can be that aren't biliary atresia. And so, and what we found recently, and by recently I mean the last probably decade or so, is that having a non-excreting or waiting for a HIDA scan and doing it with all of the appropriate preparation, which is, you know, typically 5 days of phenobarbital, actually just delays diagnosis and is not super helpful. So the only time a HIDA scan, in my humble opinion, has been helpful is in patients where you're not so sure that they have biliary atresia, they don't really fit the clinical picture, but you want to just have an additional layer of certainty. Then if you do a HIDA scan and there's good excretion from the biliary tree into the gut, then that can sort of reassure you that, okay, my clinical suspicion was correct and this is probably not biliary atresia. But on the opposite side, whenever you have a high clinical suspicion or even a moderate clinical suspicion for biliary atresia, the general advice now is not to bother with a HIDA scan. Cholangiogram is ultimately the gold standard for diagnosis of biliary atresia. But unfortunately, even this is not a great test because 20% of them can be misleading. The nice thing about the cholangiogram is usually the surgeons will do them intraoperatively. So they access the biliary tree, they put in contrast, and they watch to see whether the contrast under direct fluoroscopic visualization goes into the GI tract. If it doesn't, they usually then open up the kit and proceed directly to the hepatoportoenterostomy, which is the surgery for biliary atresia. We'll talk about that in the next few slides. Liver biopsy is safe and easily done at specialist centers in babies. It is super helpful actually for biliary atresia, and we do them now. And actually here in North America, most kids with cholestasis will get a liver biopsy at some point. There are specific features that you look for, and it can help you in the situation where it's cholestasis, maybe has some features of biliary atresia, has some features of something else. It can help you to eliminate some of those other diagnoses also. So just to give you a sense, here is what a normal liver biopsy looks like. Arjen Leber's chair, this PV is the portal vein, the HA is the hepatic artery, and the bile duct is right here. And Arjen three chizo make up the portal tract or the portal triad. Then these all on the sides, the sort of light pink, spongy looking cells towards the edge of the pictures, those are hepatocytes. So in biliary atresia, you have a number of different findings. One is cholestasis, which is both a serum definition, but also you can see this actually physically in the liver biopsy specimen where there's bile plugs. So this orange material that's plugging up the bile ducts is something. In Biju, I don't know if you can appreciate, Joama, there's one bile duct in the normal liver. There's one bile duct for every triad. Here, you'll have to take my word for it. There's many, many bile ducts here. So this is called bile duct proliferation. It's, think of it almost as collateralization. So usually if you have a block in a tube, the body finds a way to get around it, right? So similarly in this situation, in obstructive jaundice, which is the case in biliary atresia, there's something blocking the passage of bile. And so it tries to make additional routes to get to where it needs to be. And that's what you have with this bile duct proliferation. So I've been talking about biliary atresia a lot. So what is biliary atresia? So it's a congenital absence or malformation of the gallbladder or biliary tree. It's about 1 in 12,000 in the US, 1 in 19,000 in Canada. Globally, probably all in all a bit less, but in some Asian countries, particularly Taiwan, it's very much more prevalent for reasons as yet unknown. The reason it's so important to A, know about this, and B, know how to diagnose it is because how quickly you diagnose it and how quickly the patient gets the appropriate treatment has a huge impact on the long-term outcomes. So the treatment for this is basically reconnecting, and I'll show you a picture of that in a second. But the idea is to reestablish bile flow. So over the past 20, 30 years, there's been really strong data to say that the earlier you do the Kasai procedure on the baby, the more likely they are to live for a long time with their native liver and not need liver transplantation. So, I mean, it's quite dramatic. See, if you diagnose and treat before the age of 60 days of life, about 70% of those children will re-establish bowel flow, meaning they'll be able to live with their native liver for some time. But greater than 90 days, actually then less than 25% of those patients will establish bowel flow. And those kids progress to end-stage liver disease and liver failure very, very quickly. So that's why it's so important to both know and diagnose this as quickly as you can. The hepatoportoenterostomy, the Kasai procedure, is pretty well known worldwide as the really only surgical operation that can work for biliary atresia. So on the left, you will see that in biliary atresia, ducts, the tubes that connect from the gallbladder to the liver to the intestines are missing, right? They're atretic. So the bile has nowhere to go. It's made in the liver, it's stored in the gallbladder or sometimes not, and it has nowhere to go. So what the surgeons do is they take a piece of the intestine, usually the jejunum, and they basically create a new drainage system. So they basically suture it directly into the intrahepatic biliary tree. It's kind of a cool procedure, actually. So, Ajay, cholestasis and bilirubin, the main take-home points are as follows. If a baby has jaundice, if they're formula-fed more than 2 weeks, if they're breastfed and otherwise healthy more than 3 weeks, then send the fractionated bilirubin level in the blood, which is the total and direct bilirubin. Make sure to always ask and review for any red flag signs. Those are the ones we talked about, sick appearing, family history, previous children with any issues, any ultrasound abnormalities, any associated dysmorphic features, those types of things. A direct bilirubin greater than 1 milligram per deciliter, no matter what the other numbers are, is always abnormal, and you should always get further testing. And in any of these babies, right, anytime there's a concern, refer to a specialist if you, either after you've done that initial workup, or if you don't want to do the workup and you just want to send them, that's also completely reasonable. But do it as quickly as you can so that the babies can get care they need in a timely fashion. And then we talked about biliary atresia. So these are the references for the cholestasis part. And then I think, Hatim bhai, apne end per questions karsu, or should I keep going with the COVID liver piece?
I think you should continue, Batul,
Okay.
and પછી we end per karsu question.
Okay, perfect. Okay, so this is a very brief, everybody review of GI and liver issues related to COVID-19. And the disclaimer is that I only look after children, adults, growth. So, so I've tried to talk about some of the adult issues that come up. So a reminder that COVID-19 is still very much an issue. 193 million infections globally with over 4 million deaths worldwide. A pandemic unmatched in recent decades or even centuries. In the US, 34 million infections and more than 600,000 deaths. Presentation, as you guys have heard a million times, can range from asymptomatic to multi-organ failure and death. Of course, mask wearing and vaccinations are helping. But now with ongoing emergence of variants, we have to have continued vigilance. With regards to the GI system, it's long been known that SARS-CoV-2 virus can affect lots and lots of aspects of the GI system. And the big reason for that is because what we know is that the SARS-CoV-2 enters into the cells through this ACE2 transmembrane receptor. And those are expressed pretty ubiquitously in the GI tract, but really in high concentrations in the intestine and the liver, even in the pancreas. And so it's very much biologically understandable that there would be some GI-associated issues. Interestingly, symptomatically, there are a number of GI symptoms that patients will present with. Some patients have only GI symptoms. And that's a really important thing to remember, is that patients present to you with new onset GI symptoms in this pandemic. You got to think about COVID. Sometimes the GI symptoms happen first, and then ultimately they develop the fever and respiratory symptoms. And then, there are very much mixed reviews and mixed data on whether the presence of GI symptoms changes anything. So does it mean that they have a worse clinical course? Does it mean they have a milder course? Actually, there have been papers that have suggested both of those things. So I think that jury's still out on that. But diarrhea, nausea, vomiting, abdominal pain, and elevated liver enzymes are super common. Some of the, there's been a lot of talk about this sort of liver enzymes piece and what do you need to do about it. So both in terms of a patient that presents with GI symptoms and who presents with elevated liver enzymes in the time of COVID-19, you want to think about, is this COVID-19? So let's review this algorithm for elevated liver enzymes with COVID-19. So if they have a positive COVID-19 test and they have elevated liver enzymes, the question you're asking yourself is this all COVID? Do I need to do additional workup? Is this going to go away? So this sort of helps you. So if your enzymes are elevated, but they start to recover as the patient is clinically recovering, and then they either normalize or have downtrended significantly, the chances are this was all a transient sort of related to the viral infection or related to potentially any drugs that were being used in the treatment of the patient. But if they don't get better, then you've got to think about underlying causes. What we found recently is that the viral infection with COVID or any other viruses for that matter can certainly trigger an underlying autoimmune hepatitis, for example. So you do have to think about other causes, even if you know the patient has COVID. There's an interesting phenomenon that has been emerging with regards to the gut itself, and the finding that a lot of patients that have GI symptoms, or even that don't, who develop reasons to get an endoscopy. So in this particular study that is listed here with the 38 patients, most of these patients were scoped because of GI bleeding. 25% of them had signs both endoscopically, so visually and histologically, of ischemic injury. So there's been a lot of talk of COVID as sort of widespread inflammatory and prothrombotic, vasculitic kind of processes that affect many organs in COVID, but this seems particularly true in the GI tract. And for a number of reasons, right? Like if the patient is really sick and they're in shock, right? Hypoperfusion of the gut can be a big problem. Excessive inflammation that we know to be true in some of the sickest patients with COVID can lead to endothelial dysfunction, platelet activation, thrombotic dysfunction. But then also just the very idea that there are ACE2 receptors in the gut that the virus is directly binding to, the thought is that actually there's probably a direct mucosal inflammatory response and possibly even a vasculitic response that is contributing to this phenomenon. Unfortunately, management, there's not a whole lot you can do other than routine supportive care. So, in a patient who's having significant diarrhea, vomiting, think about supporting them with IV fluids. Loperamide is a Imodium chair. We use it a lot in sort of traveler's diarrhea. The most important thing to make sure of with loperamide is that you're not giving it to a patient that has C. diff. C. diff can be much, much worsened by use of loperamide. They can develop toxic megacolon perforations and all sorts of things. So as long as you're sure the patient doesn't have C. diff or any other bacterial infection, that you can use loperamide for this. Antiemetics, and then really making sure that the patients are in the ICU, especially if they have not just elevated liver enzymes, but if there are features of liver synthetic dysfunction, that is actually something that has been linked with a worse clinical outcome. So liver synthetic dysfunction, just quickly, I haven't included on the slides, but is when you have coagulopathy, so an elevated INR or PT-INR, or if you have hypoalbuminemia. Those two give you a sense, or if the patient is having, mental status changes. The problem with all of these three things is that you can have them just from having severe COVID infection also. But in that situation, you want to think about, is the liver synthetic function impaired, and make sure they're in the ICU. But even in that situation, you're still doing mostly supportive care until their viral infection is under control. I just quickly, being a pediatrician, this is something as far as COVID, for COVID, alhamdulillah, it hasn't affected children nearly as much as it has affected adults. Kids are still getting sick, and especially now being the most, the highest population of unvaccinated people is a problem. But this MISC you would have heard of, it seems to be specific to children, a specific inflammatory response from COVID that occurs in children. This is the CDC definition that we, as you can see at the bottom, all of the pediatric and liver societies are sort of in agreement with this, is in a patient who's under 21 years, they have fever for more than 24 hours, they have evidence of inflammation, and that can be elevation of any of these markers, plus if they have multi-system organ involvement, and they have a positive COVID test, you can diagnose them as having MISC. What's important about this is it's good to be able to diagnose this because it also in children determines what course of action you're going to take. Most of these children will get remdesivir. All of them need to be in the ICU. Most of them will need to be monitored long-term with sort of specialist involvement. So those are the diagnostic criteria for MISC, which is a specific clinical phenomenon that occurs in children from COVID infection. I think that's the last slide. These are the references for the COVID stuff. And I think I'm ready to take any questions.
All right. Shukran Batul first your presentation atu. Very thorough, detailed. Batul, we have few questions. So the first question is, what would be a typical diet plan with a periampullary masses?
So I guess whoever asked that question, any specific periampullary mass that you're referring to, or do you mean just in general?
I think it's a general question. No.
Yeah. Let me go back into. Oh.
We cannot hear you, Batul.
Hatim, are you still there?
Yes.
Oh, I don't know. I think I logged off somehow.
Yeah.
So periampullary masses, to be honest with you, so I guess I would need more specifics about what mass you're referring to. Generally speaking, yeah, I think that's a hard question to answer, just in terms of what kind of mass are you referring to determine.
No problem. We'll move on to the next question.
Hatim, just for the audience, I'll include my email address here at the end. Agar koi ne questions hoy, feel free to email me, and especially with this question, if you would email me with some more specifics, I can definitely help to try to answer that question.
Sure. Thank you, Bilirubin.
Sure.
The next question is, I'm not a doctor, but want to know, is the blue light treatment harmful in some other ways?
The blue light treatment for the phototherapy for children, you mean? I know it's hard. I think you mean phototherapy for the treatment of hyperbilirubinemia. So generally speaking, the only main issue, the sort of most well-known issue with it is can cause eye damage. But so all babies that are having the blue light treatment get special eye coverings to protect them from that. And then the other thing is that sometimes it can cause, if a patient has cholestasis, if they have a conjugated bilirubinemia and not just an unconjugated, it can cause them to have this diffuse rash. And so those are the two big things. The problem with not doing anything, and the problem with, so you always think about what's the risk of this treatment and what would be the risk of not doing the treatment. The big risk that we worry about when babies have a high bilirubin level that's unconjugated is it can cross the blood-brain barrier and cause something called kernicterus, which is profound seizure activity that can lead to irreversible brain damage. And so those are sort of the things that you're weighing, is the potential for eye damage that can be precluded by the right eyewear and a rash, essentially, compared to irreversible brain damage. So it's generally pretty easy decision to make.
Got it. All right. So the next question is, what new advances you foresee in the field? I'm referring to the neonatal cholestasis field in the next 5 years.
So one thing that is happening really, amazingly quickly is now we are finding more and more causes of neonatal cholestasis. There are very sophisticated now genetic tests that we can do to find. Previously, when we would often have patients with neonatal cholestasis that was sort of, otherwise unspecified, and we'd just call it neonatal hepatitis or neonatal cholestasis and have no idea how to treat it or what to do. So that's one big advancement, is that we're diagnosing a lot more things, and then within those new genetic diseases, a lot of work is being done on sort of the treatment of those diseases and even gene therapy. With biliary atresia, and this is an interesting question as far as the future of biliary atresia, people are trying to understand the cause, but the reality is that we still are not very good at treating it. So the Kasai procedure is, even in the most experienced hands, not very good. So even if I talked about getting it done within the first 60 days, even if you do that, right, the kid lives for a couple of years with their liver, but ultimately the chances of that those children end up needing a liver transplant are still incredibly high. So I think what needs to happen is, one, we need better surgical techniques for treating biliary atresia. And the second thing is, when they ultimately do need a liver transplant, that brings in a whole, other set of talks of kind of how we need to improve making patients as well as they can be before they receive a liver transplant, and then sort of all of the, how do we manage a liver transplant, all of those things. But the field of neonatal cholestasis is widely expanding, but unfortunately biliary atresia is still one of the most common cholestatic things that we talk about as hepatologists. Still doesn't have a lot of good treatment options. So that's hopefully something that will be coming soon too.
Got it. So the next question is related to Kasai procedure. Is Kasai procedure very commonly performed in big centers in the United States? Are hepatobiliary surgeons found in every children's hospital?
That's a really good question, and the answer is no. So generally speaking, and this is actually a kind of controversial, because you see most of the big center, so what we would consider a big center when it comes to liver in children is centers that offer liver transplant. So that's generally a good sign to think about, is if the center that you're thinking about referring to the child offers liver transplant, the chances are that those people have done Kasai procedures and are good at them. Some of the smaller community-based hospitals or smaller pediatric centers that don't do liver transplant have pediatric surgeons who specialize in hepatobiliary, but the Kasai procedure in biliary atresia is actually, when you think about all children, not really very common. So it's not a procedure that is done a lot unless you're in a center that gets those referrals. So I would say, based on how we currently practice, if you have if your patient has biliary atresia and you want to get them to a good Kasai, then generally think about sending them to a transplant center where the transplant surgeons are likely to be the ones that do the Kasai procedure.
Okay, thank you. The next question is delayed stenosis at the anastomosis a common problem?
Delayed stenosis at the anastomosis a common problem. I'm assuming that you mean after the Kasai procedure. Also an interesting question. So what we understand now about biliary atresia is there are different clinical phenotypes. There's like an inflammatory phenotype and a more fibrotic phenotype. Interestingly, it's the opposite of what you might think. So the non-draining Kasais, meaning the ones that, like, for some reason they just never drain, even if you do it at the right time, are thought to be, rather than delayed stenosis, it's more because of an inflammatory response at the anastomosis site. And that typically happens more with the inflammatory phenotype. There's some recent studies to suggest that using steroids post-Kasai might be helpful for that, but it's controversial still. Delayed stenosis, meaning so I guess the question is the reason that these Kasais don't work, is it because the anastomotic site becomes stenosed? It's actually less because of that and more because when you're connecting the gut to the liver, there's direct access of all of the gut microbiome into the liver. And so the biggest problem these kids have is recurrent cholangitis. And that is what then promotes bacterial colonization in the liver, liver injury, cholangitis, and the subsequent issues that come from cholangitis in terms of adhesions and things like that. Those are the issues that typically occur and are the reason that those kasais ultimately stop draining.
Got it. Okay. So one question is just briefly, if you can speak about liver transplant. How does the selection works? Are parents eligible to be donors?
I love that question. So it's a long answer, but I'll try to keep it short. Liver transplant for children is done really in two ways: deceased donor and living donor. Not all sites offer living donor transplantation, but it is a possibility. So, and parents can be donors, and in fact are often the best donors. And so, with a deceased donor, the way that so let's say a patient we decide needs a liver transplant, they would get placed on the liver transplant waiting list. So in the U.S., there's a sort of a national organ sharing system, and the nuances are a little bit complex, but basically depending on how clinically unwell, how sick the patient is, they get assigned a score, and that score determines where they are on that list and when they'll receive a transplant. On the other side, with the living donor transplants, the process is basically you decide that if we decide that a child needs a liver transplant, we would then approach the family and say, is living donation something that you would like to consider? And in the situation that they would like to consider it, then any eligible family members or sometimes even friends can go through the process of evaluation. Living donor transplantation is a little bit harder than deceased donor, and the surgical anatomy has to be thought about really carefully. And so one of the biggest reasons why we don't do it is because there's some anatomical issue with the veins and arteries in the parent or in the donor candidate that means that they won't be able to connect up stuff, do all of the plumbing well during the transplant. And then there are some patient factors that mean you can't do it too, but definitely in babies, it is an option.
All right. One last question. What should tip doctor to get COVID test in a child with diarrhea? First get the LFT or get COVID test right off the bat?
That's a good question. I think what I would say is in pediatric patients, diarrhea, COVID or not COVID, is super common. So I think, generally speaking, if the child is not unwell, not having fevers. So here's what I would say. If the kid's having fever and diarrhea and has any sign of respiratory illness, the chances are in North America, they're going to need a COVID test in order to get back to school or to do whatever they're doing, okay? So in that situation, it probably is worth getting a COVID test. If the patient is just presenting with diarrhea alone, they don't have fever, they don't have respiratory symptoms, sometimes you don't have to test them at all. If they're maintaining hydration at home, they're drinking well, they're having good urine output, you just give it time. The chances are that's an acute viral gastroenteritis that will get better. This COVID thing brings this whole new complicated layer of it. I think really I would only test for COVID in that situation if the patient is having fever and respiratory symptoms.
Got it. All right. And one last, it was not a question, but a thank you note from one of the audience. And the audience has mentioned, I do not have a question, but I would like to thank Batul for this information.
So welcome.
Okay.
Actually, Hatima, there was one other question. One therapy better than the other, phototherapy, fiber optic, or exchange transfusion?
Got it. Okay, yeah.
So just a quick answer to that is actually that's sort of the stepwise ladder of how you would do things. So phototherapy is generally a pretty effective, non-invasive, easily available thing to try first, especially in situations where the bilirubin is not crazy high. Actually, the nomogram that I showed you from Bhutani, there's another treatment nomogram too. An imaging chair, so it has the high levels of bilirubin. It tells you, depending on the day of life and how high the bilirubin is, it will direct you, should you do phototherapy or do exchange transfusion. Generally, it's worth doing the phototherapy for the first 24 hours. But if the bilirubin is sky high and you're looking at that chart and it's coming up as this patient may qualify for exchange transfusion, then it's something to think about early.
Got it. Okay, Batul. So with that, વન્સ અગેન થેન્ક યુ સો મચ બતુલબેન કે તમે તમારી નોલેજ સ્કિલ્સ અને બધું શેર કર્યું સગલાના સાથે. ઇટ વોઝ અમેઝિંગ, ઇટ વોઝ ઇન્ફોર્મેટિવ. અને આખિરમાં દુઆ કરીએ પાછા કે ખુદા તાલા આલી કદર મુફદ્દલ મૌલાની ઉમર શરીફને તારોઝ કયામત દરાજ કરે અને આપણે સગલા હેલ્થ કેર પ્રોફેશનલને આ ઓર્ગેનાઇઝેશન સીફી બુરાની મેડિકલ એસોસિએશન અમેરિકાના હસ્તક મૌલાની અને મુમિનીની ખિદમત કરતા આપણે બાકી રાખે. આમીન. وآخر دعوانا أن الحمد لله رب العالمين.